بيشرفنا ان احنا نقدم لثاني محاضرات الملتقى العلمي او ملتقى المجله العلميه لجمعيه جسر. دي هتبقى تاني المحاضرات، ويشرفنا كذلك ان هو من انف صاعدا، يعني هيكون ده تحت رعايه مكتب مصر للعلاقات الثقافيه والعلميه بسفاره برلين، وهو تحت قياده دلوقتي دكتوره داليا سلامه، وهي بتشرفنا النهارده بالحضور لاول مره كذلك. دكتور خالد الصياد هو احد مؤسسي جسر، وهو حاليا يعني هو الشخص اللي بيقود المؤسسه للامام بكل الانشطه اللي فيها، فبيشرفنا بان هو يكون المحاضر النهارده. وهو حاليا ريسيرش كوردينيتور في راديشن اونكولوجي ديبارتمنت في اونيفرسيتي كلينيكوم مينستران، وهو كذلك يعني اوبا ارتس فيها، او ما اعرفش بالانجلش ممكن تكون تشيف دكتور، او ما اعرفش
بالظبط.
تمام. والنهارده تكون المحاضره هتكون بخصوص طرق التريتمنت في حالات الليمفوما. هل يا دكتور حضرتك ممكن تبدا اظن دلوقتي؟
Okay. Good evening, everyone. Thank you, Dr. Ahmed. Thank you, Dr. Nurhan, for your kind invitation and nice introduction. At the beginning, I would like to thank also Professor Dalia Salama for her continuous support. And today I will speak about the renaissance of radiotherapy or low-dose radiotherapy for cutaneous T-cell lymphoma. My name is Khaled Elsayad. I'm a consultant for radiation oncology in Germany since 2010. And this is my outline. At the beginning, I would like to give you a brief summary about cutaneous T-cell lymphoma and the background about the disease. Then I will give you a small or few informations about radiotherapy indications and radiotherapy modern radiation doses and technical considerations. About the Mycosis fungoides. Mycosis fungoides is a very rare type of lymphoma of the skin. It represents about 2% of all non-Hodgkin lymphoma cases. Most of cutaneous lymphomas are T-cell lymphoma, which represents 70% of cases, and 30% have B-cell lymphoma. We will speak about T-cell lymphoma and especially about Mycosis fungoides, which represents 39% of cutaneous T-cell lymphoma. The origin of cutaneous T-cell lymphoma or Mycosis fungoides, it's originating from the white blood cells, especially T lymphocytes, and infiltrates the skin with cutaneous manifestations with patches or plaques. Most of cases have a very slow course of disease. We call this a chronic disease. So many of patients suffer a long time about the manifestations. And immunohistologically, we find CD4 positive and CD8 negative T cells in the histology of the patients. Most of patients are elderly, about 50 to 60 years old, and about the manifestations, as I say, patches or plaques or tumors. And in very advanced cases, patients with leukemic form or blood involvement with a diffuse skin redness, we call this a Sézary syndrome. This is a very advanced manifestations of the disease. Also, patients are suffering usually from reduced quality of life with a very severe manifestations or symptoms and emotional impact of the disease. Not only the patients suffer from this disease, also the families and the supporting teams, such as physicians or sisters at the Department of Dermatology. All of these symptoms will impact or reduce the quality of life of the patients and their families. In early stages, patients are living more than 10 years. However, in advanced cases with nodal involvement, patients have 2 years or less survival rate. In visceral manifestations, patients live not more than 1 year. Clinically, we are dividing the patients in 4 tumor stages: T1, T2, T3, and T4. In early stages, patients present with very flat manifestations such as skin redness, patch, or raised a little bit. We call this plaque, or tumor stage with a tumor more than 1 centimeter in diameter, or in very advanced case or total skin redness, we call this erythroderma. The treatment algorithm is very difficult in this rare type of disease. Patients with early stages receive treatment, usually local treatment with ultraviolet or topical or cream with a steroid or bixarotene. This is vitamin A medicine or third generation retinoids, or topical chemotherapy. However, in patients with advanced stage, will receive more aggressive treatments such as photopheresis or BUVA or vitamin A or interferon. Also, radiotherapy plays a very important role in advanced cases and also in very early cases with local radiotherapy. More aggressive cases will receive systemic treatment with chemo or immunotherapy with rituximab or mogamulizumab. The first case received radiotherapy in medical literature in Mycosis fungoides was described in Germany in 1902. This means few years after Röntgen discovery or X-ray discovery. And the patient showed very rapid improvement of his clinical manifestation. But side effects of radiotherapy was a very strong barrier between the dermatologist and radiation oncologist. The most common radiotherapy side effects are fatigue or skin problems such as redness up to skin necrosis. In female patients, hair loss is a very big problem from radiation, or nail loss or nail changes, leg edema or swelling after radiation, or skin dryness or orbital or ocular problems. I will speak today about the low-dose local radiotherapy in Mycosis fungoides. During radiotherapy, patients show very rapid clinical improvement. In these patients, we give 2 fractions from radiotherapy, 2 gray, 2x2, and the patient showed very rapid improvement of her clinical manifestations. Also, this patient received the same dose, 2-day radiotherapy, and showed very rapid improvement. What about the diffuse manifestation? If the patients have a very diffuse skin lesions over 10% of body surface area, we have to apply the total skin electron radiotherapy. This is my specializing research projects in Germany now. The first case of total skin was described before 70 years from John Trump, the uncle of the previous American president, Donald Trump. And the first case treated with the specialized total skin was described in Stanford 10 years after the first case. This Stanford technique is the standard treatment now all over the world to treat the patients with diffuse manifestations. From my department in Germany, we tried to show the patients how they should stand. The patient should be 3.5 meters away from the radiation machine. This is the radiation machine, and this is the radiation source. And here we have to put the plexiglass 20 centimeters before the patient to reduce the energy of the radiation and to avoid any severe side effects. You see the patient should be standing in 6 different positions. Every position will take about 2 minutes radiation, and during radiation patient eyes should be protected and also the patient's nails. The standard radiation dose before 10 years was 30 gray, 30 units. The gray is the unit physical dose in our department called gray, and we give this 30 gray in 15 to 20 fractions. But as you see, after the radiotherapy, the patients improved very rapid and tolerated the radiation not so good after this conventional dose. We know that this conventional dose before 2010 was very effective, but was associated with severe side effects and high recurrence rate after the radiation. So we started to analyze our patients 2015 in Germany, in my department. This was my PhD thesis, and I collected the patient before 2015 who were treated with conventional dose, 30 gray, and compared them to the patient received reduced radiotherapy doses. As I said, most of cases with conventional dose received 30 gray, and since 2011, we started to treat the patient with lower radiation dose, 11 to 12 gray in 8 fractions. Also, other researchers in America or in Copenhagen or Stanford or England also described the same outcome after the total skin electron beam with low dose. The remission rate or response rate was about 75 to 96%. However, the complete remission rate was lower than 30%. But the advantage of this low dose total skin were very significant. The minimal side effects in comparison to the standard radiation dose and the better quality of life, and short duration. Before 2010, the radiation duration was about 2 to 3 months, but with this low concept, the radiation duration takes about 2 to 3 weeks. Also, with this low dose radiotherapy, we have the possibility to repeat the treatment 3 to 4 times a life for every patient. In 2017, I tried to compare the results of low dose and conventional dose side effects together. And we found that the skin problems are significantly lower with low dose concepts. Also, the skin ulceration or erosion rate was very low compared to conventional dose, 25% compared to 76%. Now we will give more information or go deeper in the low dose concepts and the improvement of clinical outcome in combination with other treatment. This is a patient, as I said, treated with 12 gray total skin, and 8 weeks after radiation. This means 2 months, only 2 months after treatment, the patient had complete response. Not only the clinical improvement was significant, also the quality of life. We tried to analyze the quality of life of our patients before and after treatment. And Dr. Tariq Nawar published these results since a few months in Journal of American Academy of Dermatology. And we found that the most significant effect of radiotherapy was seen 3 months after treatment. So this treatment may take longer time to see the response, almost 3 months, maybe enough to see the complete response of the total skin. And not only the quality of life, also the physical well-being and emotional well-being, functional well-being, and social and family well-being were significantly improved after total skin electron beam. Therefore, in national and international guidelines, in German S2 guidelines, European guidelines, American guidelines, international guidelines, the radiation dose was 10 to 12 gray is the standard treatment, but also we should follow this radiotherapy technique with maintenance treatment or systemic treatment or topical cortisone to prolong the duration of response. Therefore, we started to analyze our patients also since 5 years to compare patients receive total skin alone with patients receive total skin plus retinoid therapy or vitamin A therapy. As we know that the overall remission rate after total skin was 70 to 96%, but the progression-free survival rate was very short, 6 to 9 months. We suggested, or our hypothesis was that radiotherapy may empower the immune system by releasing neoplastic antigens. And with the addition of pixarotene after total skin, we suggested that the pixarotene therapy may help to maintain response by increasing anti-tumoral activity in microenvironment and apoptosis of residual tumor cells. This was confirmed in our analysis. As I said, we collected 46 patients with T2 to 4 tumor stage. The overall response rate in our patients with combined modality, total skin plus pixarotene, was 96% versus 68% with total skin alone. And patients with complete response were significantly more in combined group compared to total skin alone. In addition, longer progression-free survival was observed in patients with combined modality. As you see here, this is Kaplan-Meier curve. We see that patients with combined modality, total skin plus maintenance treatment had significant higher progression-free survival in comparison with patients with total skin electron beam alone. This article is in production phase and will be available within a few weeks. Now to the current international prospective studies about the total skin in combination with systemic treatments. As I said, 10 to 12 gray is a standard of care in selected patients with Mycosis fungoides. And we should include our patients in prospective trials to try one of these systemic treatments. I will focus on the first trial, total skin with 12 gray plus mogamulizumab. Mogamulizumab is an immune therapy in market since 2 years, and it is FDA and EMA approved now for patients with Sézary syndrome. However, in Mycosis fungoides, the response rate was not so high, such as in Sézary syndrome. Therefore, we try in this prospective EORTC study to include 43 patients starting from 2022 and estimated primary date of completion in October 2026. And as I said, European Organization for Research and Treatment of Cancer is the sponsor of this study. We are trying to apply 2 cycles of mogamulizumab and afterwards to see if we can apply 12 gray radiotherapy. And after recover of the side effects of radiotherapy, we should maintain the patient on mogamulizumab up to or until progression. We hope this study will give us more benefit for our patients with mycosis fungoides in the next few years. And this is a summary of my or our team publications regarding the total skin electron beam. Most interesting is the ultra hypofractionated low dose total skin. Instead of 8 fractions, we also can give 2 fractions with 4 gray over 2 days. And this analysis now is ongoing, and I expect to publish the results within few months next year. This was my last slide. In summary, radiotherapy is the most effective single agent, as we saw, that the radiotherapy have a very high overall response rate, reaching 96%, and very good quality of life. Combined modalities in combination with pixarotine, for example, or one of the immunotherapies, we may prolong the clinical benefits of our patients. And as I said, further studies are needed. Patients with skin lymphoma should be discussed in a tumor conference in multidisciplinary approach to give the patients more chance for better outcome. Our future research in Germany, we try to find a prognostic biomarker in serum of patients or histological biomarker for better outcome of our patients. This was my last slide. Thank you very much.
شكرا جزيلا دكتور خالد على المحاضرة الجميلة دي، وأظن نفتح باب الأسئلة. يعني في انتظار أسئلة كل الحضور.
تفضل.
أنا عندي سؤال لو تسمحوا.
اتفضلي دكتورة نورهان، سامعينك.
دكتور خالد، انا كنت بس عايزه اسال حضرتك، هو انتوا بالفعل بداتوا تحاولوا تعملوا انفستيجيشن على المولكيولر ليفل لاي بايو ماركرز ريليتد للشغل بتاع الراديو ريزيستنس او الراديو ثيرابي عموما؟ يعني هل في مثلا حاجه ليها علاقه بالهيت شوك بروتينز مثلا، او اي حاجه تكون بروتينز ريليتد للثيرابيز عامه والريزيستنس بتاع الثيرابيز بالذات الراديو والكيموثيرابي، ولا لسه اوريدي ده اندر انفستيجيشن؟
بالفعل بدأنا في دراسات كمان يا دكتورة نورهان، سيرولوجيكال موليكولار باي ماركر زي CD30 already brentuximab. It's a CD30 antibody, and it's already in the market since few years. CD30. My next research
2 years.
2 years brentuximab. Thank you, Dr. Mohammed. And also
mogatuzumab.
brentuximab, I think more than 2 years, 5 years maybe. Brentuximab is CD30 antibody.
Just been out, but the brentuximab has been around for years now. Yes. More than 5 to 6 years.
5 to 6 years, and now in my research I am concentrating on serological biomarkers, not histological. I'm trying to find the correlation between the serological biomarker CD30 in the blood of patients in comparison to histological finding in the histology of the lesions. Also, we are concentrating on BDL1, serological BDL1 soluble marker, and also CTL4 and in TARC serological biomarkers. These are my specialized biomarker which I decided to investigate.
Okay, thank you so much, Dr. Khaled.
Yeah, not at all. Another questions? I can ask Dr. Mohammed Al-Shazli. Dr. Shazli, are you treating patients in Egypt with total skin, electron beam, low dose, high dose? Which concept are you using in Egypt? Mohammed Al-Shazli.
So basically, we have the start here, and thanks to you, Professor Khaled, since last year, started using the
Hello.
Definitely comparable towards the 36 grays. And the addition is that it is possible to use it more than one time with less and less toxicity, because as we all know, the Mycosis fungoides basically it is a chronic disease. We are not expecting the patient to be cured or the disease ends by a course of treatment. So we're expecting the patient to be seen over the period of a lot of years. And basically we need effective therapies. And I do believe the most effective one in controlling the generalized forms, the more difficult forms, the radiation will not be, as a player, will not be off the block. It will be there. And it is the most effective one. Adding to it, mainly from the advent of the era that we are dealing with, of the monoclonal antibodies and antibody drug conjugates, and having lots and lots of the targets nowadays, this actually puts hope in our heart for control of this very difficult disease and very relapsing disease. I don't know about you, but for anybody who is seeing patients suffering from mycosis fungoides, they will be seeing the patients for long periods of time and having recurrent relapses. So basically, we are hoping for the emerging biomarkers and having new markers on the market, and having a lot of progress in the forthcoming period, especially in the era of having more IOs and tackling the immune response towards the malignancy.
Okay, are you facing problems to get the medication in Egypt, brentuximab, mogamulizumab?
For the brentuximab is kind of expensive here in Egypt. It is around per dose around 60,000 pounds. So basically, it is not accessible except for a very limited amount of patients in comparison to the ones that we see for the brentuximab vedotin. But basically, the access to the newer drugs will be more and more limited, although they are trying their best to make it more accessible, and they're having a lot of patient support programs and stuff like that, trying to bring down the price. But the problem is that it's still inaccessible to a variety of patients that we see.
Okay, thank you. Dr. Ahmed?
With the other drugs, Professor Khaled,
yes.
Like for the toxin, the denileukin defitox, or
yes,
the other drug, it's not accessible here in Egypt. We only have the BV.
Yeah, okay. Thank you very much for your information, Dr. Mohammed.
Sure.
Yeah. Do we have any more questions?
Well, I would like to ask you about the regimens that you are doing the research on. even for cutaneous T cell, or even in the other malignancies, you're dose changing. You're moving with Dr. Debaja, and you're trying to make different doses for every kind of malignancy.
Yes, this is
so
right.
What's up for the future?
We tried since the pandemic, Corona pandemic, another radiation dose was only 2 fractions total skin, with 4 gray. This means we reduced the radiation duration from 8 days to only 2 days to avoid patient exposure at our department and so on. And we also saw a very effective results with this concept. Only 2 fractions, I think, will be the standard of care within few years if we published our results in the future. Another concept for patients with B cell, Dr. Muhammad, I didn't speak about cutaneous B cell today, but we already reduced the radiation dose from 40 gray to 4 gray by cutaneous B cell, because cutaneous B cell lymphoma is very indolent disease and don't metastasize or spread to other organs.
For all of the subtypes, or only the follicle center and
follicular and the marginal zone lymphoma? These are the indolent lymphomas, but diffuse large B cell should be treated with 30 to 40 gray. And I think when we try more studies with the combination treatment, with systemic treatment, we can also reduce the radiation dose in the aggressive types. We reduce the radiation dose from 40 to 30 gray by diffuse large B cell lymphoma already since 7 years. And I think in the future we can also reduce this concept to get more systemic effect with the hypofractionation when we use, because we know that when we use hypofractionation, high radiation dose in 1 or 2 fractions with immunotherapies, we can achieve more effectiveness in comparison with long time radiotherapy. I think this radiation concept will change in the future within 3 to 5 years maybe. And Dr. Debaja in MD Anderson in Texas is very active in this subject.
Well, I have no further questions. Thank you so much, Professor Khaled.
Thank you.
Dr. Khaled, Dr. Muhammad Shazli, also, I want just to ask, so relapse means that it was like this patient have like a complete treatment and is diagnosed like the treated like person, and then like cancer is reoccurred, or the cells were already resistant to the therapy?
Dr. Muhammad may respond.
Can you come again, please?
So my question is, Dr. Muhammad, the difference between the relapse and the resistance to the radiation therapy. So resistance for me means that the cells are not really, like the therapy is not really affecting the cells, but relapse means after complete treatment, there is reoccurrence of the cancer. I understand well or not?
So basically, to have a resistant tumor to radiation is that you have the patient progressing in spite or on therapy or within very short time from completion of the treatment. So this is the concept of a resistant tumor. But having a relapsing tumor post-radiotherapy is basically having a cutaneous T-cell lymphoma, they do relapse. This is more into a chronic disease that you need to be having a very large armamentarium of therapy and defining and profiling the patients who suffer from cutaneous lymphomas and defining or decision making as regards the therapy, whether we use local treatments like using locally acting corticosteroids, mainly using moisturizers, or more generalized therapy like the PUVA and the electron beam radiotherapy. So to juggle all of this and also use systemic agents, the newer agents that we can use, like I said, with the denileukin, the Fitox, and the BV, and using a lot of the drugs that are on the market. The problem is that we're not seeing a lot of response rates with the drugs itself, but we usually find the very impressive response rates with the radiation therapy and with the PUVA that can control the disease for long periods of time and not sacrificing the quality of life or having side effects from systemic therapy. So having a relapsing tumor, you need to have a large armamentarium that you can juggle your patient through so that you would be able to keep him alive and with the best quality of life with the least side effects for as long as this patient is under your care. I hope I answered your question, Dr. Nurhan.
Yeah, I understand now. My question was, because I'm already working, but on the molecular level, not the clinical point of view, on the radio resistance in triple-negative breast cancer cells, and I'm trying to investigate on the molecular level the signaling pathways that are like responsible for this resistance. That's why I was asking, what's the difference between the resistance and the relapse? Yeah.
Okay. So having a resistant breast cancer or a triple-negative breast cancer, and defining that even in the triple-negative breast cancer, it has a different origin. It originates from the myoepithelial cells. It does not from the ductal cells or from the lobular cells that we are usually handling the breast cancer, and the genofiling that you can do or that was done. And nowadays you can exactly know the cell of origin and the mechanisms of resistance and the incorporation of the BRCA genes and how they may go into the interplay between using the drugs that we use to attack the breast cancer. It's a bit, breast cancer is heavily studied and researched, and we have a lot of data about its genomic profiling and how this resistance evolves. The problem with the cutaneous or the Mycosis fungoides, it's not that common. We don't have a lot of patients, and we don't have a lot of collaboration so that all of the different entities that treat these rare tumors is conducting a lot of research in this disease entity, and especially the areas that has no drugs and pharmaceutical companies that can sponsor clinical trials and like do some influx of money in this disease area so that it will fund research. You will not have a lot of answers, and you will not have a lot of people interested to know about the results of. I'm sorry to take the floor for a long time, but the questions were.
Okay. Yeah, but it was really informative to have this discussion. Thank you so much.
Dr. Mohammed Al-Shazli is a chairperson of the Scientific Oncology Society in Egypt, and it's a great honor to have you today here, Mohammed.
Thank you so much, sir. ربنا يخليك يا دكتور خالد. شرف لينا.
أي أسئلة ثانية؟ تمام، الميكروفون مع حضرتك يا دكتور أحمد.
طيب أنا عايز أشكر حضرتك يا دكتور خالد على المحاضرة دي وكل المشاركين معانا في الأسئلة على المناقشة الجميلة دي، وكنت يعني حابب أعرف إذا كان في أي حد عنده أي تعليق أو أي سؤال عشان نختم. فأشكركم جميعا تاني على حسن الاستماع، وعلى دكتور خالد تاني على المحاضرة، وكلكم على المشاركة، وبانتظاركم بإذن الله في المحاضرة الجاية بإذن الله الشهر الجاي. شكرا جزيلا جدا.